So, what is tuberculosis? Tuberculosis is infections of the part of the body by Mycobacterium, Mycobacterium species Bacterium tuberculosis, and it affects all part of the body except the nose, the hair, and the teeth. The teeth. So what is the causative organism for TB? TB is caused by Mycobacterium tubercle in human being and also Mycobacterium bovis in animals. So other causative organisms of Mycobacterium is Mycobacterium africanum, Mycobacterium microti, and another type of non-Mycobacterium genus is Mycobacterium repli, which causes leprosy, Mycobacterium avium in bands, and also Mycobacterium asiaticum. So tuberculosis complex is caused by Mycobacterium africanum, Mycobacterium bovis, and Mycobacterium caneti, and Mycobacterium microti. So what are the characteristics of tuberculous bacteria so that it can be a leading cause of infections and be difficult to treat? It's a gram-positive microbacteria with the obligate aerobic and non-spore-forming non-motile rod and mesotile, and it measures 0.2 to 0.6 times 2.4 micrometers. It slowly generates to 15 to 20 meters, and that means it contributes to the virulence. So it has a very lipid-rich cell wall with lipid, which contains mycolic acid, 50% of it, in a dry cell. And this one is the one which makes it to have those responsible many characteristics of this Mycobacterium properties. It is an acid-fast bacilli. That means it retains the acid and confers resistance to the reagents and the antimicrobials. What is the classification of tuberculosis? Tuberculosis is classified broadly into two KNN, that is pulmonary tuberculosis, which can be a primary disease in the pulmonary and also can be a secondary disease in the pulmonary. So again, it is also classified as an extrapulmonary tuberculosis, which affect the lymph nodes, and the most common lymph nodes affected of tuberculosis is around the neck. Then we have the pleural cavity, which the cavity surrounds the lung, and also have a TB, which it can develop either pleural effusion. There is the TB of the upper airways and also TB of the skeleton, TB of the genitourinary system. There is medial tuberculosis, pericardial TB, and gastrointestinal tuberculosis. There is TB of meningitis, and there is common other forms of TB, like TB in the kidneys, TB of the nails, and TB of the joint. So TB epidemiologically, TB is that it is one of the leading cause of comorbidity in patients with HIV/AIDS, and to some extent it is 50-50, especially here in Mombasa and also in Kenya. It is almost 50-50. 50% of the patients with TB have HIV/AIDS, and 50% of patients with HIV/AIDS have TB. But generally, you can see a study which was done in the year 2004 shows that TB in places with more than 3,000 per 100,000 population is around Africa, almost the whole of Africa, except around 3, 4, 5 countries, which are the far countries near them, near the far Prince Asia. So TB is a big burden, is a global conditions, is a problem of the world. And you can see that countries like Asia, in Asia, that is in India, it has 59%, in Africa, you have 26%, and East and Middle East is 7.9%. The European is 4.3%, and the Indian of America is 3.3%. In terms of advanced in technology of treatment and diagnosis of tuberculosis in places like European region and American regions, the key factor in terms of TB in Asia and Africa is because those countries have they are developing countries, they have a high population, and again, the infrastructure, they have the sanitation, the housing, all of them, and the nutrition status of people in those countries is one thing. Now you can see that India is the leading cause of burden in terms of tuberculosis in the year 2010 in a study which was done in the year 2010, followed by China, which also has a big population. We can know that the population of China, South Africa is a big country with a lot of populations. Then you can see Indonesia, Pakistan, these countries which you can call the curves of the Middle East. Also, they are coming up as a coming up economy of those two countries which are having some good cases of what? Of team big game. Then you have Bangladesh, Philippines. These are countries with low middle income countries like and it's also that means the infrastructure, the sanitation, the housing factors, the nutrition factors, and also the structures of the health. They are kind of one thing in those countries like Bangladesh and the Philippines. So we have the Congo, the biggest Africa, in terms of space, not well populated. We have Ethiopia, another big economy with a big population, which is around more than 100,000 population. We have Nigeria, which is more than 50,000 population. Again, we call them the Africans. Nigeria and Ethiopia, they are part of the countries in Africa. We call them the Africans, the lions. They are bigish populations, and the valleys population there is like overcrowding, and the TB since is a airborne disease, rather and droplet disease. That means the transmission of the disease is high. So we can see that Kenya is down there. Is also Kenya is a big economy with around 50 million people. That means it's a country with a big, it's also classified as one of the the African lions. That means it's also a country with a good population, which has TB. And you can see that you have 120,000, 120,000 in terms of total cases of TB in the year 2010. So you can see other countries like Tanzania just there. You can see that Uganda also is a big economy. It's also part of the big economy of Africa. We call them the lions of Africa. So you can see that basically a considerable number of countries there with big populations are a burden of what? Tuberculosis. So that one can significantly say that population is a big factor to contribute to TB. Despite the countries like Congo, where it is showing what you call in statistic, it is outlier. The population is big, people are scattered, and yet they have a considerable number of TB. So it's a good area of study to study TB in Congo so that you can understand what is happening in Congo, because it's not a big country here. And most likely the reason is that there is most likely the reason most likely can be there is no infrastructures of health. And now you can see still India takes of 21% of the world population, but then in the globe, and you can see that China is there, number 14, Indonesia, Nigeria, South Africa, Bangladesh, Ethiopia, Pakistan, and Philippines. So those are the countries with big problems. Now you can see that TB in terms of incident rate in different ages is that the incidence more than 55 and above is the people with TB, and these are people who have already started having non-communicable diseases like hypertension and TB. So TB comes in as a secondary infection. Again, those people are very outgoing. They are doing a lot of jobs. So those people get TB. So you can see that in terms of age group, tuberculosis is like a runner. The more you grow, the more you have a chances of developing TB. So, and the younger you grow, the lower chances of having TB. Despite that, you know that diseases plays a big role in terms of the extremities of life. But this time, the incidence is behaving in a funny way that you can see that it is very another. So that the more you grow, the more you have chances of developing tuberculosis. So this is something else which requires to be understood properly. Or we can say that in 5 to 14 years, most likely the BCG is playing a part, but that is something which needs to be discussed in another perspective. So that means there is a gap of study. Why is that TB is behaving like that? Plus, is it exactly the way it is in the ground, or this type of data is biased? Good. Now, as we continue now, let us look at the number of deaths. The number of deaths secondary to tuberculosis is high, that is around 700,000, 7,000. Then you can see that the tropical diseases are very low, and then HIV is number 2, measles. So you can see TB is the leading cause of death in terms of in that study which was done that time. What are the causes of spread of tuberculosis? Is coughing anyhow, spitting everywhere, and also crowded places with poor ventilation. So when it comes to terms of coughing, you have to remember the cough etiquettes, the good manners in terms of coughing. You have to close your mouth, or you have to cover your mouth when you're coughing. Keep away, never cough in a place where people are many and that spit everywhere. So the cough etiquette are very important in terms of prevention of what? Of tuberculosis. So the symptoms of tuberculosis are not very clear. They are very vague, but there are some symptoms which comes out very clearly. So persistent coughing is a very common type of TB and chest pain. But in so many cases, the chest pain start then cough follows, and this patient coughs brand sputum in some cases, and also as a shortness of the blood. There is discolored urine, and there is crowned and redness urination, and fever, and chills, and fatigue. And wasting, night sweats, and also loss of appetite are all factors which contribute to somebody to be suspected to have tuberculosis. So basically, the type of TB you have determines the symptoms you have depending on the functions of the organs or structures of the body which are affected by tuberculosis. For example, if you have TB meningitis, you will have manifested features of a CNS, central nervous system, like dizziness, headache, and throbbing, or you can have coma, seizure, all those type of things can manifest with the tuberculosis. Then you have a chest problem. TB, you could have manifest the features of chest, like coughing, chest pain, and then if you have TB of the urinary system, you have problems in the urinary system. So per se TB symptoms carries the factors, the structure and the organs affected. If it is affected at the utmost degree, that is the time. So basically, there is no classical. We can see we don't have very classical symptoms of TB. So what are the steps in physiology of tuberculosis? Very well in pathology that you know that tuberculosis is an example of a disease which initiates chronicity from the word go. So the macrophages plays a big role in the first point of infection. So there is an exposure, then the droplets the droplets of nuclei you cough, then somebody inhales them, and in some of these people's, what inhale, 50% of the people or more, they are not don't have the infections, but in other people, the bacteria reaches the lungs. Around 25 to 50% of the people, bacteria reaches the lungs in the alveolar species, and this place it initiates an inflammation process where the macrophages comes and engulf the microbes of TB, which causes the disease, and then the granulation process taking place, and it is surrounded, and that part which is sick, affected by TB, is cut off from other functioning of the lungs, and this is the reason why TB develops cavities, and this is taking place in a normal person with a normal immune. But in patient who does not have a strong immune, this one does not affect. It follows another pathway of urinary tuberculosis. So in this case, the bacteria ceases to grow, and this corresponds in 83% immunosuppression. In immunosuppression, it reactivates and causes another TB. And then in other patients, then it is coughed out through the cough reflex. And also it can purify and spread to other part of the body, the other part of the body, the blood and the organs, and this one can cause TB death. So let us look at the types of tuberculosis, which ones we mentioned earlier on. We said that tuberculosis can be either pulmonary tuberculosis, and pulmonary tuberculosis can either be primary or secondary. So in a primary tuberculosis, we can see that the infection is of an individual who has not been previously infected or immunosuppressed is called primary tuberculosis or chronic Bones complex or childhood tuberculosis. The lesions forming after infection is primary and accompanied by ELA, which may be not detectable on the chest radiograph. This is very common in children. So we have the secondary tuberculosis, which is affect people who had previously been sensitized to TB and post-primary infection of chronic tuberculosis, and this is what we call a secondary tuberculosis. So we have extrapulmonary tuberculosis, of which the patient, 20% of the patient have this type of TB, and it affects various parts of the body like lymph nodes. And I say that the patient who have this type of problem, this is very common along the neck, types of lymph node. Symptoms is painless swelling of lymph nodes, most commonly at the cervical and supraclavic part, and systemic are limited to HIV infections in this type of people when they have HIV infection as a co-infection. As a co-infection, then we can say that the systemic are limited to HIV infections. So those are most of the people who have this systemic type of TB. Then we have periodal TB is involves periodal cavity, is common in primary tuberculosis and result in from penetration of the tubercle bacilli in the periodal species. TB of the upper airway, it involves the larynx, pharynx, and epiglottis, and the symptoms are dysphagia, chronic reproductive cough, and chronic reproductive cough. So we have genitourinary tuberculosis, we account for 15% of all extrapulmonary cases of TB. Any part of the genitourinary tract get infected, and the symptoms urinary and infected dysuria and material. So in this case, you remember that we said that the TB depends on the site of infection. Then you have secretor TB involving the weight-bearing part like the spine, hip, and the knees, and that means the patient will manifest with the joints and the knee pains. Then you have gastrointestinal TB, and then good thing with gastrointestinal TB is that it responds well because the drugs taken are oral. So when you take the drug at the point of absorption, that is where TB is handed there directly pap. So it is a good TB which responds well to treatment. Yes, which responds well to treatment. Then we have the other type of TB like TB meningitis or TB tuberculoma, which is count for 5% of all extrapulmonary TB, and this one result from hematogenous spread in primary and secondary tuberculosis. So TB pericarditis is a TB which can account for 1 to 8% of all extrapulmonary tuberculosis, and spread mainly in the mediastinal or iron lymph nodes of the lungs. And then you have miliary or disseminated TB result from hematogenous spread of the TB bacilli, spread due to entry of bacteria into the pulmonary vein, resulting into lesion in various sites of the chest. And this type of TB looks like when you look on X-ray, it looks like a spread of millet. So we have another less common type of extrapulmonary tuberculosis like hepatitis, panoramitis, and PNF hypersensitivity related to pyotubular conjunctivitis. All these ones are types of tuberculosis. So diagnosis, how do we diagnose TB? Diagnose, basically you have to do a proper history taking, and also you have to do a proper examination of your patient so that you can suspect tuberculosis. Yeah. So in this case, is that you have to know that TB diagnosis is based on doing a bacteriological test. You can do a Zen L60 or reticular acid arachofast bacilli. You can do gene expert. You can do a sputum for culture and sensitivity. Also you can urinary staining of the sputum. Then you can do sputum culture. And also you can do a chest X-ray, and you can see a very good tubercle there of tuberculosis. At that point, a very good case of tuberculosis at that point, so that you can see that affected area. Then also you can see nucleic acid amplification of the TB, and also you can do nuclear of TB. Then also you can do what you call tubercle skin test. That is what you call a tubercle skin test. It's called Mantoux test. Is the basis of Mantoux test is equivalent to the principles of BCG. Then we have the interpretations when you do Timbaco test interpretations. So the Timbaco interpretations of TB is if the diameter is less than 6 millimeters, that interpretation is that there is no TB, and the key thing you have to do is prevent the patient from what? TB, and by doing basic things and also adding up the BCG vaccinations. If the millimeter is 6 or greater but less than 15 millimeters, then there is hypersensitivity to Vivacrine and protein, and maybe due to previous TB infection or BCG exposure to a type 4 mycobacterium. In this case, don't give BCG, continue observing and checking on the patient. Then we have, if it is more than 15, then there is hypersensitivity to TB, antibody protein and Sanjeta TB infection or disease, and this one don't give BCG, refer patient for further investigations. Most likely you may intervene by doing what we call TB therapy. So what is pathogenesis of tuberculin test? It is that there's antigen antibody reaction. That's a type 2 hypersensitivity where you induce the antigen in the body. Then you can see that the T cells attack the antigen. Then they present it to dendritic cells. Dendritic cells are the cells of the immune system which are concerned with the memory. Then they remind the body to start producing cytokines. And these cytokines is like a tumor necrotic factor, tumor growth factor, and other things like cytokines like IFNY, interleukin 1, interleukin 6, interleukin 8. These interleukins need macrophage recruitment and polymononucleocytes, leading to cellular infiltration and swelling. That is now, if the swelling result, that one means that this one results to what? To tuberculin, or what you can call a Mantoux test. So other biological examinations, you can do serum blood count. You can see the lymphocyte will be increased. You can see protein, Pande and vector test, ascites, perio, and efficient, and all these ones we check on them. Then the other one is how do we prevent TB? You have to use mask wherever you suspect TB. You have to do vaccines, regular medical follow-up, isolation of the patient, ventilation, and natural sunlight, which contains ultraviolet rays for the purpose of what? Killing the microbacteria of tuberculosis. So in this case, personal hygiene is the key thing in TB. Immunization, healthy lifestyle, and environment are the key thing in terms of TB prevention. So BCG vaccines, first is the 1921. BCG means Bacillus calmette volin. Only vaccines available today for protection against tuberculosis. It is most effective in protecting children from TB disease and given 0.1 ml intradermal, and the duration of protection is 15 to 20 years. Efficacy is 80%, and should be given to all infants as soon as possible after birth, unless the child presents with the symptoms of HIV, AIDS, or a full-blown TB case of a patient. Now, how do we manage tuberculosis? Tuberculosis is managed by a first-line drug like isoniazid, rifampicin, 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 and danbutan, and pyrazinamide. So second-line drugs is cyclosporine, vinamide, levofloxacin, moxifloxacin, and gatefloxacin, and alpha-aminoxidilic acid, and streptomycin, and mecacin, and calamycin, and capromycin. So the first drug in terms of TB is rifampicin and danbutan and pyrazinamide in our setup. So these types of drugs, they have various mode of actions. For example, isoniazid, it inhibits glycolytic acid synthesis. Glycolytic acid synthesis, that is where it works. It works at this point to prevent mycolytic acid. You remember that mycobacteria has that mycolytic acid to be very unique in terms of the reason why it causes TB is very unique. So you have rifampicillin, which blocks RNA synthesis by blocking DNA-independent RNA polymers, and then pyrazinamide, which bacteria slowly metabolizes within a single environment of phagocytic or acidic granuloma. That is where it works. Then we have the other one, which is Dendriton bacteriostatic, inhibit arabinocyl transferase. It inhibits that. Then the oldest drug in terms of TB is streptomycin. It inhibits protein synthesis by disruption of the ribosomal functioning. There is various side effect of this disease, of these drugs, rifampicillin of anti-TB, and it is very important for us to understand that. So rifampicillin, they can cause large liver dysfunction, flu-like syndrome, and red-orange urine drug interactions. And the most way you monitor the AST, you will reduce liver consumption, and you also monitor hepatitis. Reduce the dose into twice per weekly, and you assure the patient that they have to follow your patient very keenly. So as an niacin, you have fever, chills, and hepatitis, you stop the drug. Monitor liver function test, you administer vitamin B6, and administer B6. Pyrazinamide can cause hepatitis, monitor liver function test, and reduce the dose to 15 to 30 milligrams per kg body weight. Then you have a diabetes can cause hyperglycemia, you monitor uric acid, and also renal function test and gout. It can also cause optic neuritis, and also you have to reduce the dose to 15 milligrams per kg body weight daily for the last 2 months. So then you have to monitor the eye check using the Chiari Karam book, and then you can also check on the streptomycin, amikacin, and the acromycin, and that one can cause ototoxicity and renal toxicity. So you have to be very careful. You have to monitor body, blood urea, and nitrogen for the purpose of the renal, and also you have to check the ear if there is any problem of the ear. Also, you have to do a full renal function test. So the dosage is intensive phase and continuous phase. In intensive phase, you give 2 months of isoniazid and the whole dose, rifampicillin and ethambutol. Then you continue with the 4 months of isoniazid and rifampicillin. So recommended dose for initial treatment of tuberculosis drugs is the drugs are there. So that is the WHO drug regime for TB. So DOT is direct of sound treatment. This is where you have to observe the patient taking drugs for the last 2 weeks, months, so that you ensure the patient is taking. And this one can be used in our setup by use of community health workers who can assist you to do the same. Then you have multiple drug-resistant tuberculosis, the TB by strain of Mycobacterium. So in a multiple drug-resistant TB, it is at least isoniazid and rifampicillin the most effective anti-TB drugs. Globally, 3.6% estimated of multiple drug-resistant TB, and most 50% of MDR TB cases are estimated to occur in China and India. And you can see this is a place with a big population. So in that one is the discipline of TB. That is countries with more than these are the countries with big cases of multiple drug-resistant tuberculosis. So extensive drug-resistant TB is a form of TB caused by Mycobacterium that is resistant to isoniazid and rifampicillin, as well as pyroquinolone and any of the second line other TB injection drugs, amikacin, kanamycin, and caprimazine. So TB and HIV, TB and HIV. Worldwide, the number of people infected with both HIV and TB is rising, and the HIV virus damages the body immune system and accelerates the spread at which TB progresses from harmless infection to life-threatening conditions. So the estimated 10% of activation of domain TB, normal TB infection over the lifespan of an infected person is equal to 10%. If HIV infection is superimposed. So it is the opportunistic infection that most critical HIV patient people. It is tuberculosis. So epidemiological impact, the activation of latent infection, people who have infection with both HIV and TB are 50 times more likely to develop TB and only infected with TB. So primary infections, neotubercular infection in people with HIV can progress to an active disease very quickly. So recurring infections in people who are caused by TB, cure of TB. So how do we diagnose TB in HIV/AIDS? In HIV/AIDS, the sputum is not always common, it's not always positive, and also the chest X-ray does not have a lot of cavity. So clinical diagnosis is the key in TB patient with HIV/AIDS. And that is the end of today's lesson about tuberculosis. Thank you very much for listening to this.